Welcome to the second half of the afternoon sessions of Living in Las Americas. We're glad you could join us. And I'm here to introduce our next set of speakers, Elena Kolidobrova, Cynthia Pope, and Reynaldo Rojas, and they're going to be talking about COVID-19 responses in the Americas. And we'll start with Elena Kolidobrova.
All right, well, thank you so much. All right, so can people hear me? All right, I'm kind of loud. Yeah, right. I see people moving masks. Does that mean I can take my mask off? Yeah. Yes. Yes. All right, so first of all, I want to show off my mask. I don't know if people saw my mask. If you could read my mask, it says, "No one is illegal in stolen land." Okay, so first of all, and I want to say that this conference, I missed maybe the beginning, so I want to say that the talk that's happening is occurring on the lands that belong to the Wagank and Tunxis people, and a number of other people who have been displaced, and their memories are still being held by people who are still around. So, yay for indigenous people, nay to the colonizers, just saying. Okay, all right, on that. So just in case people haven't figured out where my politics are, you know, like, okay. So 1, 2, let's see how we go. Hopefully you'll get to hear some folks here. All right, so we'll talk a little bit about is life and language in times of COVID, play on some literature out there. So this is a nod to my English department, just in case you haven't figured out what department I teach in. All right, so the work here is that's being reported is in Quechua and Shipibo, and if you've had a chance to look a little bit at my bio, this is not what I work on. I'm a sign linguist. So if you want to know why I wound up doing work on Quechua and Shipibo and Iskanawa as well, and a number of other things, you can ask me about that later. So I won't talk about that right now. This work is in collaboration with Liliana Sanchez in University of Illinois in Chicago, but none of this would have been possible without all of these amazing people. There's a ton of people in Peru. There's a ton of people in the US. There's a number of other collaborators who you will see if you check out our website, the link to which I will show you as well. And I hope you notice that among all of these people, there's only 2 white folks. I am one of them, and the guy in the middle, there's nothing central about him. He just happens to be the only dude from Canada, right? Like, so we're the only 2 white people. The rest of the folks are either indigenous or minoritized in some other ways you can think about. Okay. So I want to say thank you to all of these folks. All of this work has been done in collaboration and particularly in bequest of indigenous folks in Peru particularly. This is how it started. Okay, just a little bit of a background. We've heard a lot about the pandemic from the speaker earlier today, but we know a couple of things about this. We know that the pandemic news traveled right away, but in some places it traveled faster than in others. We also know that this information that came around, it came around in dominant languages, right? It came around in English, came around in Spanish, came around in French, and it came around in these international and domestic structures, but what it didn't do is that it didn't reach out the populations that were minoritized, right? And it did not reach them out in the way that was appropriate for these populations, right? And so what it affected in particular is rural communities, indigenous communities, and deaf and hard of hearing communities, right? And so one example, for example, is this stuff from Peru. This is official information from the government of Peru. You can check other countries very easily. This webpage is all in Spanish. Now, it is also available in 20 other languages, but in reality, there is a ton of other languages in Peru. We'll talk more about that. There's only like 3 radio spots in 32 languages, but there's a ton of others in Peru, right? And so the question is, is this what we ought to be doing? Is this how we ought to be reaching the people with this critically important health information? The answer maybe is not, right? And so the other piece that warrants our attention is the fact that the information that was traveling out to communities was done in very kind of a cartoonish form, and in the form that it was not representing communities at all. So if you look at the kind of posters that were reaching out communities in Peru, you'll see like these kind of white hands that were being washed under hot running water that were completely not at all part and parcel of the discourse in Peru, right? Just whatsoever. That was not me, okay? Yeah, that was very exciting. And a lot of what was in fact representing people in any way, shape, or form looked very sort of, animated, right? Very children book-like, infantilizing already oppressed communities. Right, so what a number of people had noticed, ourselves included, that these methods of delivery of crucial information about health, and a number of you work already on this kind of issues, is not appropriate and does not match culturally accepted practices at all. And this, of course, creates further problems in terms of access, in terms of increased risk, and so forth. So what we wanted to do back in, we started noticing this, of course, in March, but particularly in August, what we wanted to do, we wanted to understand what the perspective of various aspects of COVID-19 was on these, in these language contact situations, and how indigenous language in communities that were culturally divergent from the social dominant languages, which were typically an additional language, L2, we're creating barriers, right? That's what we wanted to do. We also wanted to see what kind of change we as linguists could be making, right? Like, what could we do? How could we contribute to a different set of affairs, right? And what that would mean is creating guidelines for materials aimed at various types of populations. And while we were doing that kind of work, we wanted to see whether we could do some language documentation. In other words, we wanted to see whether folks who were listening to COVID-related information in indigenous communities in places like Peru, but not necessarily just Peru, but we started in Peru, were understanding the messages that were coming at them, and whether that matched the kind of messages that the World Health Organization was throwing at them. We wanted to see whether these messages were aligning with the culturally accepted practices, and we were able to do both of those things. We wanted to ask and work with indigenous structures to create the right kind of materials, and we wanted to document the languages. And that is sort of what the study is about. So, Peru. We focused on two parts of the country. You'll see, nope, okay, this doesn't work. Yeah, maybe it does work. I don't know if you can see the light. Maybe, I can't see. So you see the territories that are highlighted. So those are the places where we went. One area is in the Amazon. The other one is southern part of Peru. This is Indian languages, and that's in Quechua, that's Cusco. Both, I should also mention that we went to the rural communities, but we're interested in the rural communities and their perceptions. And so the situation was complicated. There's 48 languages in Peru, the latest count, in 55 communities. So we looked at Shipibo and Escanawa. Those are the two languages the two languages that are spoken, well, among the many others that are spoken in the Amazon. And Escanawa has only 25 people that now speak this language. And Quechua has a ton of speakers, and we have 70 folks across 11 different communities in the mountains. the instrument was a interview that we had put together that actually allows to check for proficiency levels, which is something I'll show you in a minute. So here's the instrument, and you can take a look at this yourself. This instrument has been translated into various languages now, and it's fully translatable across linguistic families. It goes between sign and spoken languages, so it's fully mobile. The first part lets you see the demographics. The second part lets you see what languages you have in the family, as well as language attitudes. And the third part deals directly with the health crisis. Now, this version of the instrument is pivoted directly to COVID, but it certainly doesn't have to be pivoted to COVID. It just happens to be pivoted to COVID because this was the health crisis under examination. So what did we find out? Somebody keeping time? Yes, okay, perfect, right. So what did we find out? We found out that we have a ton of participants that were pretty evenly distributed in terms of gender, as you can see. And the vast majority of our participants, and you see this in figure 2, considered themselves to be indigenous, right? So these were indigenous people, most of whom have or self-described and as described by the interviewer, and the interviewers themselves were indigenous people. These are community researchers, right? Describe the participants as native or near native users of the language, right? So these are the folks who hold indigenous identity and linguistic identity that's associated with the community, right? And so the distribution of languages and communities is in figure 4, right? So Quechua, Shipibo, Iskanawa, and there's some folks who speak both, and many are bilinguals. Okay. So about 78% report some knowledge of Spanish. And about a quarter of Shipibo speakers report lack of appreciation of their language. And most of these people are actually bilingual speakers of both Shipibo and Iskanawa. So there is this language attitude towards Iskanawa, and we're looking closer at this. Most of these folks show that they are second language learners of Spanish. So these are not people who are growing up with Spanish, right? They learned Spanish later in life. If you want to know more about this, you can ask me. Figure 6 represents all the various, the table really, all the various places where people use Spanish, right? This is going to be important because this actually shows up as a variable later in the analyses. So some people have 0 Spanish, and other people use Spanish in a reasonably wide variety of places. And what also is going to matter for us is that quite a few folks have heard of COVID. So this data collection begins at about September, October, we start data collection, and quite a few people have heard of COVID. There are some that had not so much, though. This is figure 7. And at this stage, 94% talk about COVID as the disease. So this is really important because disease is a very much culturally connected point, right? Our keynote speaker talked a little bit about this. What is the disease, right? In Peru, there's 48 different linguistic communities, and all of them talk about the notion of disease as being something different. Right? So Quechua hablantes, right, so speakers of Quechua talk about disease as a visitor, for example, right? So somebody who you have to prepare yourself for, but you don't actually want them hanging in your house for all that long, right? It's kind of like your mother-in-law, right? You want them at your house, but also, 3 days. Yeah, come on now, right? So what is the notion of disease? So this issue has to be explored somewhere. But Shipibo people do not talk about disease in the same term and using the same terminology, right? So, but by and large, all 100 people that we have looked at talk about, just about all of them, talk about COVID-19 being a disease, right? So lots of people made references to some kind of gravity. 24% made reference to potentially serious outcomes. Some talked about some sort of contagion language, right? airborne things. I mean, not everybody used the term virus, obviously, but there was kind of language about that, right? Lots of people talked about plant medicine, and we'll see this in a minute in more concrete terms. The vast majority, about 97%, talked about plant medicine. That thing that connects them to the land and connects them to their own way of healing. We'll see this in a second. Right, so some vocabulary that came out for this particular disease, for this virus. In Quechua and in Shipibo, we found those. Some terminology for Quechua, for prevention rather, from Quechua and Shipibo, and I'm quickly going to go through this, and I will let you take a look at them on your own. I'm happy to share the slides because I want to get to the results. So you will see this in a minute. Folks talked about cleanliness, they talked about medicinal plants, they talked about mask wearing, and I will show you in a minute how all of this came out in terms of analyses, and what to do in terms of self-care, and what to do, right, what to do in terms of self-care in Shipibo, and in Quechua, and that's a little bit different, and you'll see this in terms of analysis. So this is one of our participants, or two, rather, one of the families of our participants. And so after we've collected all of this data, we sat down for an analysis. What we wanted to see was whether there was any way to predict how folks were going to sort of talk about risk factors, symptoms, preventions, myth busters, let's say myths that came to us from the World Health Organization or something else that is more appropriate to the cultural makeup of the linguistic community, and some language effects, for instance. So it turns out, not entirely surprisingly, says the linguist, right, the language of the survey, also known as, for us, as the L1 of the community, so the first language of the community, and language of information delivery actually mattered. So for example, risk factors were mentioned at different rates by Quechua and Shipibo speakers. For example, some risk factors, the ones that the government of Peru had been pushing extensively, like obesity, were not mentioned at all by Shipibo speakers, while others, like the elderly, were mentioned at higher rate. And I'll show you this in a second. And Quechua speakers who reported having received information in Quechua only mentioned more risk factors in general than those who reported hearing this information in Quechua in Spanish or in Spanish. Right, so let me go over this again. So here are my graphs for those who like to stare at data. I'm that person, can't help it, right? So what a figure on the figure 6 shows you, that's the one on your left, is that Shipibo community and Quechua community are more or less talking about the same things, but at different rates. And the one that's spiking out is the elderly. And the Shipibo people are talking about the elderly being at risk much more. Right, same country, the same information floating out, but Shipibo community seems to be talking about different things. And also, figure 7 shows you that if you got this information, all of this COVID-related information, in your indigenous language, you were that much more likely to talk about these risk factors, even though you may have reported no in Spanish. You may have reported no in both. Right. In other words, indigenous language matters, and getting this information in your indigenous language matters. By the same token, all of the participants were that much more likely to increase in mentioning symptoms as a whole. The same, in particular for Quechua speakers, if you got the information in Quechua, you were that much more likely to talk about them again. So here's symptoms. Figure 9. If you got the information in Quechua, you were that much more likely to do that. Okay, so, all right, thank you. So, one piece of analysis that gave us some interesting information is the language of diversity of context, of language of, the diversity of context for Spanish, right? So the language of the survey and Spanish diversity of context have a impact one another, right? So overall, Quechua speakers mentioned prevention measures more than Shipibo speakers. We've already talked about this, but I'll show you this in a minute. And various prevention strategies are mentioned. We'll see this in a minute. Weak evidence mentions masks and social distancing increases as diversity of Spanish use of context increases, right? So I'll show you this in a second. So here's that. So if you look at this slide under this set of figures, what you'll see is there's different kind of prevention strategies that are being talked about. That's figure 10. And figure 11 basically says, my Spanish, like the more places I use Spanish, and you might remember this from the table, the more likely I am to talk about different kinds of prevention strategies. That's what that really says. The one thing that doesn't get affected is plans for treatment. And what we now see here is as follows. Folks, so I'm going to spend a little bit more time on this slide, even though I have a limited amount of time. I will let you all have these slides to look at your leisure. Folks who use a lot of Spanish at home, well, in their contexts, are still connected to their plants. Now, why might that be? I'm just going to go directly to this. Posta is a day clinic. So the vast majority of our participants actually have very little connection, very little access to the health clinic. But turns out, if they have access to their health clinic, they have that much more of a chance of, the access to health clinic provided us with the model that showed that they will actually talk about various prevention strategies. So you go to the health clinic, you hear about prevention strategies, like that's what happens, right? But if you don't have access to the health clinic, what else is there for you? Well, the only thing that's there for you is your plans. Now let's talk about the access to the clinic. When we ask our participants what it meant to have access to the clinic, people talked about 8-hour walk. Okay, I want to see a show of hands. Who thinks 8-hour walk is actually access to the clinic? No? No, I'm not one of those either. So 2 more slides I want to show, or 2 more graphs I want to show you because I'm trying to be mindful of time. Right. This graph on the right, which is figure 16, suggests that as the days go by, at least for symptoms, at least for the mentioning of symptoms, people are becoming more aware. Like they're hearing information more. And so on the bottom you see Shipibo, on the top you see Quechua. Shipibo people are mentioning symptoms less than the Quechua people, but maybe if we continue, so the data collection goes all the way into April, Maybe if they continue, no, what did I just say? November, I'm sorry. If we continue collecting the data, maybe they will eventually meet. But there is this big gap. There is increasing awareness. So like if we give people this information in their indigenous language right away, like maybe we'll see something different, right? Now, one thing we ask folks is, how did you get this information, right? So we know what language you got this information, but how did you receive this information? And how would you have rather received this information? For instance, did you get it through the radio, like altoparlante, right? Like one that sits in the middle of the square? Did you get it from Facebook or some other social media? Did you get it by TV? Like, how did you get this? Did you get this from your, somewhere in the chakras, like in the fields? Did you get it from your neighbors? Did you get it from your community leader, like the mayor? How did you get this? And so what people are saying, the blue one is how did you get it? The orange one is how would you rather have gotten it? What people are saying is, sort of continue doing what you're doing, except please give us something else. Have somebody come and talk to me. Like, don't just, throw information at me. Have somebody come talk to me. Have somebody tell me what it means for me so I can discuss and engage, right? So now this is a problem, right? Because what do we do in terms of a health crisis? Like, if there is a pandemic, if you have to quarantine, like, how do you do that? But turns out it's possible, right? Because you could bring a curandero. Curanderos walk around. This is what they do in a place like Peru, right? Right. So what we have done is we have, in fact, engaged indigenous nurses and curanderos who are walking around talking to people and exploring this, and we're creating materials for this. Hopefully, I will be able to show you what this looks like. 3, 2, 1, maybe. Where there are actual conversations with people that could be then played on TV or on the radio, maybe. No? No, that's not showing, is it? That we were showing before, was it? Okay, can we play it now, though? Can we? Okay, let's do a radio version. So this is a curandero and a person talking, right? It's playing here, and it was playing right before y'all came in, so I don't know what to say. That's not mine. Okay, so. So, the point to be made, the two communities did not perform in the same manner, though it's possible that this is a function of time. See the food for thought. Language has a clear effect. If COVID info is delivered in the indigenous language only, the relevant crucial information is more likely to be mentioned. Diversity of context of the dominant L2, namely Spanish here, but of course, depending where you go, this could be English, this could be French, right? So the story goes. It has an effect on mentioning the crucial information, but also whether the participants perceive certain information to be correct, right? One thing I did not mention here for the sake of time is folks with more exposure to Spanish turned out to be more people, to be exactly the right kind of people who said that bleach was the way to go, right? Okay. All participants rely on the knowledge of medicinal traditional treatments, and all of this suggests that we actually have to be working with the indigenous systems and indigenous health systems and indigenous healthcare educators. So on this, with this I'll stop and we'll send this to anybody who's interested. You could also, of course, check our website. Hopefully this will also work. As I am trying to get there. Maybe. Right here. I gave you QR, and I will give this to you. You can Google it. Yeah. All right. Thanks. Thank you.
Exit out of there. No. Yeah, that was hers that she was just doing. And it was working before. That's it. Perfect. No, same. No. Oh, that's nice, so I can see the slides here, the progression of the slides, and this is working okay? Oh, this is working fine, okay. Great, well, thank you for that wonderful presentation. It's so interesting to hear about the diversity of the Americas. Latin America is an incredibly diverse place, and I do think, just following on what you had said, when we talk about Cuba, and when we talk about, is the microphone on? Kathy, I see you leaning. Can you, is the microphone actually?
This is not really mic. This is just, it's not a mic. It just
Okay, so that must be why, Kathy. So is it better for me to talk like this and just shout?
No, we need the microphone because
It goes to the WebEx.
Okay, but you're saying you can't hear it too well.
You gotta be loud.
Okay, so I will actually shout into the microphone.
Yeah.
I apologize to everybody out there. That's perfectly fine. But to go on what Elena was just saying, when we talk about Cuba, and we certainly talk about this in my Latin American studies courses, and we talk about health, and we talk about the decimation of the population of the Americas, and this Cuba was one of the places where you still see, right now you see very little indigenous influence there. 90% of the indigenous people were killed within the first 50 to 100 years, depending on the documents that you use. So when we're talking about Cuba, we're talking about a very different demographic landscape than what we just heard about. And I think that's important to mention here. So thank you for bringing that up. So I'd like to talk about Cuba's response to COVID-19. And you know what? I have a timer, but you're timing too, aren't you, Kath? Thank you. It's very disconcerting. I keep looking at the clock back there, and it's always 12:03. So I think I started about 2:13 or so. So I'd like to talk about what we talk about in medical geography. And I should say I'm a professor in the Department of Geography. I also teach in Latin American studies, international studies, and gender studies. I want to talk about how the system has responded in Cuba to COVID-19 and to epidemics in general, I would say, but also how these responses represent the ideas of geographies of risk and geographies of resistance. So I wanted to give you a quick snapshot, if you don't mind. Oh, it's hard to see from here. I'm sorry if I do this. Okay, that's okay. Well, I can't see over there, but it's going to be a quick snapshot. Is there a way to make this so that I can see this over here?
If you go right here, you can see both of those slides. Do you see this?
Can you tell me where I should go?
Yeah.
And we're talking. Technology is good. Okay, that's okay. That's okay, and I'm sorry to those out there in cyberspace. I'm just going to have to read from the slide. I should say that Cuba has had a very strong response to COVID-19. It is prepared for disasters, whether it's climate change, whether it's hurricanes, or whether it's epidemics or pandemics, particularly in the healthcare system. It's considered to have a very strong healthcare system, but I do want to make sure that we problematize it a little bit here. Perfect. Thank you so much. That's what I was looking for. Thank you. So I really recommend that if you're interested in Cuba, check out the site for the Ministry of Public Health. It's updated every evening at midnight with the current caseload. And I'm going to show you some of that a little bit later because I want you to think that health is also political. And healthcare systems are inherently political. And I don't mean they're political just because of different parties. It is how power is disseminated through a population. So when we're looking at Cuba, it's going to be different than how we in the United States look at health. In Cuba, health, despite a lot of problems with the government, which we can certainly talk about, but health is considered a universal right. It is a common good. Access is measured in number of steps, not number of hours to a clinic. In the 1980s, for example, there was the family doctor program was instituted. And that's literally having a family doctor on nearly every neighborhood block. There's a lot of doctors. Okay, you're not going to not be healthy in Cuba. Let me just put it that way. So when we're talking about COVID, it's important to note that Cuba its geography is inherently important. It's an island. It's easy to block who comes in and to monitor who leaves. Okay? It is a communist country. It has a centrally planned government, and people's movements are monitored. So like I said, there's good and bad to everything. The revolution that came into power on January 1st, 1959, the revolution giveth and the revolution taketh away sometimes. So I don't want people to think that Cuba is inherently bad or inherently good. And sometimes when I give these presentations, people get wrapped around that notion. Is it good or is it bad? It's both. All countries are both. But when it comes to healthcare, it's really a unique case study. And COVID is even more unique. So currently what we're looking at, it's a population of about 11 million. They had a low COVID rate. Let me just move ahead one slide real quick. Okay, so it's moving ahead for me. And so that's what we have here. That's okay. You know what? We can just do the way we did it before because I don't need to read anything else. I'm going to memorize that right now. So I just want to be able to show this. That's okay, because you know what? Do you mind if I speak while we're doing this? We're talking, we're just chatting. Don't mind us. So they had a very low rate. Cuba was able to control its borders, and it was able to monitor the virus before it came in. It was also able to prepare for the virus. So there are quarantine centers, for example. There are plenty of hospitals. There are places where people can quarantine on the one side. And I'm going to talk about kind of the other side of that in a second. What happened is I wanted to show you a graph, which I might show you today or not. But it was going to be a fun activity. But they got hit really hard at the end of July, beginning of August this past summer, 2021. Do you guys know what happened with COVID then? Same thing that happened in the US. Delta, the Delta variant. So as Cuba was opening its borders little by little, letting some Cubans come back, some people leave that had been quarantined there for a while. As that movement of people was happening, so was the movement of the virus. And so Delta really impacted them. And what I mean by that, it's not as if they weren't prepared for it, but the population was susceptible to that news. Yeah, we're going somewhere. Now we're going to watch this. Oh, no, still can't move it. But that's okay. It's a different slide to amuse people's eyes. Yeah, certainly. It's just being slow. Okay. See, it's Cuba. It's Cuba. Everybody's watching us. But what happened is the Delta variant entered Cuba. And so you started to see a real spike in numbers. And so when we're looking at the numbers, the deaths, for example, when we're looking at the number of infections, there's been about 920,000 infections with COVID since the beginning of the epidemic. About 8,000 related deaths reported to the epidemic, and most of them have come since that spike in July and August. So what's happened, though, since then is something that a few speakers have mentioned. that we thought would solve everything, and that's the vaccine. In the US, it hasn't, because there's been some hesitation. There's been the media, which other people have mentioned, and some really erroneous messages from the public health sector, like the CDC, for example. In Cuba, you really didn't have those mixed messages. Okay. People knew how to prevent the virus, but they also have a very strong biotechnology sector. And that is also, I would think, unique in developing countries as well. So they take a very modernist, if we want to use that word, intentionally use that word, approach to healthcare. While people do supplement their healthcare with herbs, that's becoming much more of the norm, especially as the effects of the U.S. embargo have really curtailed a lot of the importation of medical products. We're seeing more and more use of traditional herbs, whether they're indigenous herbs or really a lot of cultural practices from West Africa. I would say we're seeing more and more of that. But what has been the factor with Cuba is the vaccine. They have their own biomedical program. They create their medicines, many of their medicines, in-house. They educate the doctors, and again, education there is free from kindergarten through PhD. The other side of the equation is you don't get paid a lot once you get educated, but you do have that education. And when you think about education as a common good, it makes sense that you would have so many doctors practicing in the biomedical industry, because to some extent, yeah, of course you need a salary, but you're also giving back to the country. So I think in some ways there is that patriotic mantra that you may hear. So what you see is a vaccination. It's being approved by or being looked at by the World Health Organization, but it has been approved within Cuba. And in Cuba, like I said, it's a centralized government. When there is a literacy campaign, when there is a vaccination campaign, oh, something just changed. No, it didn't. When there's a vaccination campaign, everybody will be reached. It is hard to get by the nurses, the doctors, the students who are practicing to become nurses. These are all people who can deliver vaccines in Cuba. So it's reached a point where, and I was hoping to get to some of these slides because they're really good. I feel like I should just pass the laptop around. I know. We're fine. I'm just describing the slides, but it would have been so much better. I was going to ask them questions.
They are good, I can see.
They're so good. They're so good. And I learned to put things in the background. You would have been dazzled. But so what they have now, though, are they have 3 vaccines, just like we do in the U.S. And they have a very robust vaccination campaign. So you're going to be vaccinated, let me put it that way. And it's either going to be at your workplace, at school, the doctors will come to you. But you will be vaccinated. It reminded me of what we were talking about in the keynote address. Maybe not to such the dire consequences that they will go and get you and take you in their secret van and vaccinate you. No, they'll just sweet talk you to death or stay in your house until you get vaccinated. And you just want them to go. I get it. So, but their goal is to have 90% of the population 2 and up vaccinated by December 1st, and they're on that trajectory. It's over 7 million people out of 11 have received that first dose. You have a second dose 2 weeks later, and a third dose 2 weeks after that. So that part of the campaign is very successful because they are very organized that way. And I'm not sure what's happening here, so I'm just gonna pretend you're seeing nice pictures because some of this, shoot, I really wanted you to see. So when we're talking about geography, we do talk about different levels of risk. And again, you're going to be able to see this. I'll share the presentation. But we talk about neighborhood scales and geographies of risk, and you may be able to relate to this with other presentations. So if we talk about where people are getting COVID, and I should say I've been doing work in Cuba since 1997, so it's really, I was starting work with HIV and AIDS, and so it's really interesting to see the progression of how Cuba deals with the pandemic and how they really are, I think, as a government trying to introduce social justice or individual rights a la the US, because it has It has been a rocky road in a lot of ways. With HIV, they were able to quarantine individuals with HIV, which really no other country in the world was able to do because of ethical issues. So when we talk about risk, one thing we talk about is geographies of risk. So that's one scale. So in geography, we talk about levels. What you might hear it in history as levels. In geography, we talk about as scales. So a scale of risk. So we know that it's risky being in crowded areas. And we use the term social distancing. We went from 6 feet of social distancing to 3 feet of social distancing. Now, one of the things when you're in Cuba, and I'm sure other parts of Latin America, it is difficult to maintain that social distancing. Right? Think about your customs, your daily routine. You say hi to people, you hug them. A professional setting, a handshake, but think about the kisses. The kisses on the cheek, the 1 or 2, depending where you are. If you're someplace especially saucy, maybe 3. But you have close contact to each other. Think about your living quarters. One of the things that the revolution did was get rid of homelessness. You won't see people on the street, but you will see extremely overcrowded housing. So it's almost guaranteed that if one person in that home gets the virus or the flu even, common cold, everybody is probably going to get it. So one of the issues with quarantining, even though there are facilities, how can you quarantine so many people at one time? So that did become an issue. And just your daily movements. How do you keep 6 feet amongst people, between people, when you're taking public transportation? People don't go in their cars the way they do here. Cars are extremely expensive. And actually owning a car, you were not allowed to do that as a private citizen really until 2009. So transportation to get to work. If you're going to work, you have to be in contact with other people. And we call it social distancing, but I was trying so hard with a colleague of mine in medical geography to call it physical distancing. I don't like that term social distancing, and you can't make me like it. But the physical distancing, because when you say social distancing in certain cultural context, it really changes your lifestyle. So when we talk about geographies of risk, we can talk about it at the individual scale, and then we can talk about it. How are we doing with time? This is just very weird, isn't it? I am on that one there. And then we talk about many people in Cuba became infected through healthcare centers. Another irony. So even though masks were distributed, the vaccine was not available at the time, and there still was overcrowding. It was very rare that you would actually be able to maintain 6 or even 3 foot distance. Cuba also, everybody lives in the streets. The houses, you don't have air conditioning systems unless you're, in one of the muckety-muck neighborhoods, and there are very few of those. So your windows are open all the time. Your doors are open all the time. People are coming and going. Children are running in the streets. It's just haphazard there, but it's absolutely wonderful. It's a sign of life. So when the government did try to impose some of the same measures that we did in the U.S., they really weren't as successful as could be expected in the U.S. In the U.S., we are very individual focused. We have our houses. We close the windows. We close the doors. We're in our individual people movers. We can stay home and we can teach online. They couldn't necessarily do that there, but they still had a relatively low rate of corona until the Delta variant hit. And that was really a deciding factor in the deaths increasing. But also at the same time, because of the strong biotechnology industry, those vaccines are now available. And so from 2 to 11. Okay, so we're still waiting for approval in the U.S. from the ages of from 5 to 11. 5 to 11 is going to be our next one. They're administering it from kids 2 through 11. So I think in that way it's going to be quite successful. On the other hand, because there's always on the other hand, those vaccinations have not been approved by the World Health Organization or been really reviewed outside of Cuba. I don't think that that's going to be an issue, to tell you the truth. I do think they're safe, but we'll have to see because no international organization has really verified them. And so again, one of the things too I just want to bring in real quick, again, I wish you would have seen the slides, but, we're seeing slides now. Hold it, what just happened? Okay. So if we look at the national scale, let's see where we are now. So we're at the national scale over here. The role of physical geography I've mentioned. The idea that it's an island nation, so it's somewhat easier to control epidemics. You can tell who goes in, who leaves. We also have, the role of the embargo cannot be minimized either. One of the problems that they're having, and I wanted to start the talk with this and then got so distracted, was me muero de hambre, no del corona. So I'm dying of hunger, not from corona. This could be about Cuba. So Cuba's witnessing a really interesting time of change. While I think they're going to be able to defeat, I mean, sorry to use that militaristic term, this virus, but it's also, that's the way they talk about healthcare too, in a very militaristic fashion. There's other social factors that play into who is at risk that are going to continue well after corona. The idea that there's food shortages. This is incredibly important. People are having to line up for food. So again, if there's other viruses that are going around, they're not going to be able to maintain that social distance or that physical distance. But people really are suffering from more malnutrition than they have in the past because of the global supply, the supply chain that's broken down since Corona, I would say. And then also some national production of food that has also decreased because of lack of oil, really, for the equipment. And so what I was hoping to end on is just real quick, the role of the National Healthcare Program. This is taken from the Ministry of Health's website. But what I thought was really interesting, why I put this image up here, it's from a couple days ago, is it shows side by side. On the right, you really have up-to-date corona information. And again, you can check this out as well. This is a public site. But on the left, it brings in some of the political situation there too. And so it talks about the medical brigades, and such. And oh, that just moved without me wanting it to. And so this is where I am going to end, because something has happened. It's very Halloween-y up here today, is you often see Cuba's healthcare system as a source of pride. It's a way that they can compete globally. They may not be a wealthy country, but their social systems rank among the best in the world. So here you've got the United States, and you see what our levels are at now. And I'm going to have to do this, I'm sorry. 66% have received one dose, 57% have been fully vaccinated. Cuba, 85% at least one dose, this is as of yesterday, 55% have been fully vaccinated. So they often compare themselves to the US. So I'm going to end there. I am sorry for taking up so much time, but thank you very much for your patience. And I can certainly send this presentation around to anybody who would like it. So thank you very much for your time. I'm not touching anything else up there.
Speak from here. Thank you. So my conversation then, or my presentation, is about trying to address this impact of COVID, or trying to investigate how are we dealing with it locally in marginalized and oppressed communities, with innovative programs, especially in communities that have been impacted by trauma. So I've been working for the last few years here in New Britain in the East Side neighborhood, a neighborhood, pretty close to campus, but it's a neighborhood that's been marginalized and it's been impacted by trauma, both individually and collectively. And so they got a grant recently, and they've been trying to do work on what they're calling, again, trauma-informed community development, and trying to work in the community through that trauma, right? And try to assess the trauma, deal with it, to then create a healthier community that can create leadership after that. So I cannot see here, though. I don't know. I mean, I can see it there, but
You see what I'm saying?
yeah, it's crazy. Yeah. All right, cool. So I just do it and click, right? Right. Okay. So again, the definition of trauma-informed community development, it's informed by the lived experiences of trauma, both personal and collective. So you have to understand that trauma to then address it. So it's a framework that establishes and promotes resilient healing and healthy community. That kind of word of resiliency that I worked before through folks that came here for Hurricane Maria. My research was trying to investigate and do research on their level of resiliency and how that did improve. So here I stepped into resiliency to a different model in a different neighborhood. But this seems to be a common word right now, coming from disaster areas and coming from natural disasters. It has gone into now, how do we work with this through impoverished and marginalized communities? And the goal is to heal enough a community, heal enough people that they can realize their potential, right? Because we know that trauma impacts your ability to progress and move forward. So again, individual trauma in these marginalized communities, we see a lot of mental illness, homelessness, substance abuse, domestic violence, incarceration, sexual or physical abuse. So again, communities that have gone in an individual level through many, many levels of trauma, sometimes pass to their families, sometimes the community itself, but then there's a collective trauma in these neighborhoods that it's sometimes create the conditions to cause individual trauma, right? Like substance abuse or homelessness. But there is, in the collective, we can talk about poverty, lack of opportunity, lack of social capital, communities that tend to be isolated and marginalized, lack of stable housing, which then ends up an individual issue of not finding housing, right? So that instability is neighborhood-wide, not individual. Communities that are segregated, we know the impact of violence in the community. That's why sometimes you may be walking down the streets and you get assaulted or something like that through crime. So then that community violence ends up impacting you. And in a larger aspect, community disinvestment. Neighborhoods that have been kind of passed over or marginalized by the powers that be, right? So again, in these communities, we have a high level of community need, historical disinvestment, disempowered and lack of ownership, that's very traditional of marginalized and oppressed communities. Loss of distrust, which is part of what you have to heal, right? People have heard all kind of stories before about how we're going to fix your neighborhood, we're going to improve it. They don't trust you anymore, right? Instability, unreliability, and inconsistency. Promises are made, but nothing gets accomplished time and time again by politicians, by powerful figures. Residents are seen as consumers, right? We talked earlier about capital and how people are seen as a commodity. I think Dr. Phillips mentioned that, and they're not seen as partners or empowered residents of those communities. And people who live in those communities have a difficulty envisioning the future, envisioning positive change, right? Not only I'm dealing with my trauma, but this neighborhood has collective trauma, so they don't see it. So again, the neighborhood that I've been working on, historically neglected here, high poverty levels. The interstate highway is part of the story, Route 9 of the East Side neighborhood. He cut it from the rest of the neighborhood. You go into Britain, there's a lot of this kind of efforts in Britain to improve the neighborhood. Oh, it's not switching, but I'll keep talking. So we have all these efforts to, you moved it here though. So you have high poverty levels. There's constant fears about crime and personal safety. We found that a lot when we're doing our surveys. The community partner that I'm working with, which is the YWCA, they find a lot, with time they do service in the community, they find a lot of fear and a lot of, I don't feel safe here. The fast track, there's a fast track that there's a stop right in that neighborhood, but people don't necessarily use it because they don't feel safe and they don't feel, that they want to use it. There's broken sidewalks, abandoned buildings, and there's a perception of drug dealing and other criminal activity, despite the police being partners and say, listen, there's not as much crime here. We don't respond to here as much, to ensure that it is not as safe, but the looks of it, people just still feel it, right? So, the statistics might tell you there's not a lot of crime here, but people don't necessarily feel safe. There's a certain dilapidation of the neighborhood, and that has to do also with a lot of investment in downtown New Britain to really beautify downtown and all this stuff. But again, this neighborhood gets cut off by the highway, and it's kind of, it's just, they don't feel the investment in it. Ooh, I can't see. Right, I'd rather see it here than there. Every time you switch it over there, then I cannot see it here. So I'd rather have it here and not there. All right. So again, about 10,000 residents, almost 11,000 residents, 26% did not graduate high school, 20% female-headed households, which we know is one of the highest predictors of poverty. About 18% families in poverty, 14% in deep poverty, about 25% rates of depression and mental health, suicide, obesity, physical inactivity. And again, the issues are compounded by a dilapidated neighborhood that does not promote engagement with it, right? There's a brand new park, right? So again, this is constant thing. So, and you had complaints, well, we built you a new park, we did this for the neighborhood, why are you guys still complaining, and why don't you guys take advantage of it? And so the answer is that collective trauma, right? So then the concept of trauma-informed community development has three main stages: one of engagement, one of healing, and then one of building towards the future. And so the first one is also called community support or engagement. So again, it's building trust in the community. It's really engaging with them, getting to know you, trying to build that cycle of distrust and I don't know who you are, broken promises. So you start assessing their need, providing services that they can feel are reliable. Things that I need that are here that I can provide to you and build trust that we are going to try to meet your needs, right? So a food pantry, a clothing pantry, transportation assistance they needed, also entertainment, right? With my students, we have helped create community festivals, right? This summer they did 2, right? To get people in without any specific agenda. Even though, yes, there's an agenda behind, you're trying to talk about health, and you're going to see how we're trying to talk to them about COVID, but we want to get together, we want to have entertainment, we want to have stuff for the kids, community activities, and have fun, music. So you want to also have people reinvest back in the neighborhood and reconnect with each other, right? Peer-to-peer, relax. So that's part of the strategy. And then once you have them engaged, this process will take a while. It's not something you do in a day. This might take several months, maybe a year, on that engagement process. Once you got that, then you start the healing, right, to try to deal with that trauma. And so hopefully you connect into a local health center, right? We talk about somewhere in Peru needing these day clinics. Well, some of these neighborhoods need a center that is close by to them that can provide services in their native languages. Maybe it's Spanish, maybe it's Polish, but something that they can connect with. So these issues are down in Peru and down in our communities. How can we connect with them? Micro interventions. In this case, when the YWCA got this grant, COVID became a target of intervention, right? Because the virus is raging, and how do we work with this community? So then, can we do a vaccination clinic? Can we do diabetes testing? Can we do depression assessments? Can we do services to try to heal and to try to deal with the compounded trauma that this neighborhood has? Trauma response teams, people in the community that can respond to complications with mental health, with community violence. There's a shooting somewhere. Yeah, the cops should be there, but also community healers, community workers, a response team that can deal with that and try to help people deal with the trauma of that shooting or that violent event. Listen to the community and create conflict resolution. A lot of times, if we have youth violence or gang violence, the issue is preventing that. So trying to deal with this conflicts before. Here recently in New Britain, we had a lot of fights in the high school, right? And the mayor response, was let's send more cops in, right? And the principal of the school is like, well, no, let's try to work with these kids. They spend a year and a half away from the school in their houses, and we got to give them a chance to reacclimate. And a lot of it is dealing with stuff in the community that they bring to the school. We have the largest school in the state, right? With a flat funding for 3 years, but let's send the cops, right? So come on, right? They need more social workers. They need more healers that can talk to these kids and prevent. So sometimes dealing with the conflict in the community, right? What you have beef with who? So that's part of trying to heal these neighborhoods. And then the last stage is leadership development, right? Now that the community is healing and you're dealing with that trauma, the impact is to increase the level of agency of the residents, form leadership groups, participate in decision making, which again, they're disempowered. So you want them to engage, create an agenda for social justice and social change, not by us, not by the university, but by them. So you gotta work with them and facilitate the process. I tell my students, as community organizers or community activists, you are facilitating the process, you're not leading it, right? Which is hard because we know, and like, no, you gotta let them lead. Again, build strategic partnerships, break that bound of social capital that they don't have, so connect them with larger groups outside. So this is kind of, you're not seeing is a diagram of theory of change, is that you're dealing with the roots of the problem, and then, flourishes as a tree. And so part of the plan here that they're doing and I'm gonna go to what we're doing before I finish, is a HOPE plan, right? It's the acronym HOPE, right? So health and well-being, right? Focused on, relief strain, right? Overdue bills, adequate health care. What are the things that are stressing you out? Let's see how can we help you. Maybe there's some funding we can connect you with. Maybe there's a way to forget these bills. Tell me what's stressing you out and we can help out. Opportunity making. Try to build economic capital and social capital, access to training programs, build skills. The P is for placemaking. Right, create resources, improve the neighborhood, engage with the police department if the neighborhoods don't feel safe, but also engage, let's invest in this neighborhood. Let's repair these streets. That empty building's been there 20 years. What can we do about it, right? Who's the owner of that building? Can the city put something in there? Even apartments, something to relive in this neighborhood. So invest on the place. And then engage influencers, connect with people to build a strong bond of social capital. That's the plan, right? And put it into perspective. So the most important thing that they're trying to do as a why is bring in what they're calling behavioral health community organizers. So it's not a community organizer by itself, but focus on behavioral health. So people that can come in, right? And while they're organizing, they're also connecting and helping people. That's the essential of dealing with that trauma. So the BHCOs, Behavioral Health Community Organizer, I know we love acronyms in social work, so I'm throwing these acronyms, but let me explain it. So the BHCO has to reflect the values, culture, and history of the community they serve. So it has to be, the idea is to be residents from that neighborhood, first of all, not an outsider. They build resilience and facilitate healing through empowerment, bring resources, cultivate relationships, very important to connect with the people, and work to realize community stability through personal stability, right? So it's essential. So what they did, the East Side Center, which I'm working with, they already engaged. So it was a great opportunity to they're already being slowly connected. So the grant comes in at a perfect time. They decided to train teens from that neighborhood who they already were working with. Very important. And they trained 8 behavioral health community organizers, 8 teens whose families live in that neighborhood. So let's work with these kids, and they trained them throughout this last summer, and 2 adults, 2 community organizers they have hired. So they have 10 people trained in this type of model. How do we engage with the community? And they started right away, right? Early in the spring, they did their first community event as part of this. And the target was COVID, because, the grant was adjusted to like COVID's here, so how can we work with the impact? People were losing their jobs. Some people were getting sick. Some people have lost family or relatives. So part of the target was, let's try to, we have a high number of residents unvaccinated, right? It's a predominantly Latino neighborhood. there's other ethnicities, and so we know the high prevalence of COVID in those communities and the high degree of disinformation that we've been talking about. Our communities get a lot of this information in their language. We've been targeting a lot of this information in the main languages, but recently I was reading an article. We might have taken Alex Jones of YouTube, but there's a Vietnamese Alex Jones that's still on YouTube, and nobody is. But this is the guy that the Vietnamese community is watching because they're having on YouTube, not because they want to, but they believe that he's telling the truth. So why is he not banned, right? He is the exact same model, and so how do we target this issue? So building trust and connecting with the community. For example, and I'm almost concluding, in the spring, when they did a community event and they had a vaccination clinic, nobody showed up to get vaccinated. I was like, it's okay, people will show up. Throughout the summer, they keep getting the training, outreach, talking to people, trying to get the right information. When they had an end of summer event, 15 people came and got vaccinated to the vaccination. Small number from 0 to 15. It was important in a neighborhood that's, I think, in the Bremer was the highest of unvaccinated folks in there. So they have a lot of work to do. So at the same time, they're doing surveys and connect with people to try to find out why you don't want to get vaccinated. What is the fear? And the results are like, well, I hear from this, I don't think it's safe. Same kind of information. So how can we target that? And part of it is trust, right? They gotta build trust. And if those kids go to we started with their families. Some of these kids have families, their parents who didn't want to get vaccinated. So it's like, Mom, Dad, come over to this. This is safe. And so try to work with that. And so at this point, again, the first event, we had about 100 people in the spring event. We have about 500, 250 families, about 100 people who came to the second event. So slowly, I'm not going to say it's working, but the results are there. More people get vaccinated in the second event, more people attended the second event. So I think they're starting to connect and talk to the community. Now in the last stage, 13 residents expressed interest in forming a leadership group. Right, they want to get involved. They feel that the NRZ, the Neighborhood Revitalization Zone Committee, is not hearing them. So why don't we create another one? So we're going to try to provide food and daycare so they can come to the event. So now it comes to the stage, even though the other two stages are continuing, we're starting to hope that this model gets some residents engaged in a more in-depth transformative change with this group of people now that they're trying to create a leadership committee. So again, dealing with the trauma is important, and I'm going to leave it there. And hopefully, I don't know if you have a few minutes for questions. Thank you.
Hi, and I know that it's time in terms of the official schedule, but we have one cancellation in our next panel. So if we have any questions, we could take a few minutes to ask and clarify some of the things for the panelists today. Hope everybody. Yeah, Evelyn. Dr. Phillips.
The process of having an election right now. You have Latina and also the current mayor running. So have news organizations invited them over to discuss what their plans are for the east side in Britain.
Not at this point. With that,
Hey, Reynaldo.
especially now that we're working campaign.
Yeah. So our online viewers, which we do have,
yes.
we do have some great online viewers. And could you repeat the question?
Yeah, the question is that New Britain is in the middle of a campaign, right? The mayor, and there's a Latina person also running for mayor. So is the group of residents in the east side, or this new group of residents, there's a current group, but again, the new group feels that the old group is not listening, and because we're working from a different perspective, they hope that it's a different approach. And so the question is, are they inviting the candidates to speak? They haven't, but I'm pretty sure that should be a good opportunity to bring them to the neighborhood. Not with promises, but let us ask you questions. Let us hear us out, right? I know it's every 4 years only, but hey, if they're running, let's let's hear our concerns and what can we do. So I think it's a great opportunity. So definitely will recommend that, So thanks for that tip. Any other questions? I know I have some of my policy students here. I don't know if you guys want to ask a policy question, but I think all our presentations have policy implications, from working with indigenous people and what's the best approaches to then looking at the examples, comparative analysis, what's happening in Cuba, what's happening here. We tend to think that they're not doing that good. Well, they're doing better than we are because their approach to public health is different than ours, right? So, and again, this issue of trauma. So anybody can ask a question or anybody else?
Britain is in a red zone, it has a high rate of COVID.
Yep. High rate of COVID, and especially the marginalized neighborhoods like this one, high rate of COVID. And it's part of the disrupted marginalized communities, but definitely disinformation and, poor health. I mean, there's part of that trauma. It's high diabetes, high heart disease, high levels of the best of nutrition, right? The bodegas, if you talk to the bodega owners, they'll bring better food, but a lot of fast food, a lot of poor diet foods, in the bodegas. So it's, I remember in Hartford, we did a project where we were talking to the bodega owners to try to bring the fresh produce to the front, get the chips out of the counter. And they listened. And nobody told them to. They were great. So they put the chips in the bag, right? Instead of in the counter where people grab another chip or a soda. So sometimes they will partner with you if you talk to them, but you gotta just reach out.
I just wanted to say how brilliantly these work together, and thank you all. I think of the issues about geographies and languages of risk and cultural, and national policy issues just fit together. It's a really useful way.
Sylvia. Yeah, come over.
All great presentations, thank you, but we talk about the vaccines.
Yeah.
And so, they were manufactured in Cuba.
Yes.
How long did it take for them to actually manufacture and get the vaccine out to the population? You know the time frame that?
About the same time as the U.S. Yeah, because we had all, it looks like around the world, especially in the Americas, we had seen the virus occur at about the same time, right? March 2020 or so, and that's when we were starting to impose restrictions, February, March. They started ramping up the technology there. They've got the ability to do that. Like I said, they've got a strong biotech sector. They also have the materials that are available. They import them from several countries, not the U.S., unfortunately, because of the U.S. embargo. But they can do a pretty quick turnaround. They also do, they create vaccines in a different way that some of the U.S. scientists create vaccines as well, which we can talk about later if you'd like to. But yeah, they ramped up very quickly. It's a really good point. Yeah.
Thank you very much. I think we can let this panel finish. Thank you very much for coming and attending. Great panel.